At the outset, I just want to explain the role of the Royal College of Nursing. It was founded in 1916 as a professional organisation for trained nurses. It was granted a Royal Charter in 1928 and it became a registered trade union in 1976. The College is obligated, in accordance with our Charter, to promote the science and art of nursing and education and training in the profession of nursing, to promote the advance of nursing as a profession in any or all of its branches, to promote the professional standing and interests of members, to assist members who, by reason of adversity, ill health or otherwise, are in need of assistance of any nature, and to promote through the medium of international agencies or purpose in other countries as well as the United Kingdom. The Royal College of Nursing has over 400,000 members, health practitioners, nursing students and registered nurses, and we have 14,000 members in Northern Ireland. My name is Janice Smyth. I am the Director of the Royal College of Nursing in Northern Ireland, and I appear before you today accompanied by Garrett, our Deputy Director, and Roisin, who is a member of the RCN Northern Ireland Board, a member of the RCN UK Emergency Care Association, and a member of the RCN Northern Ireland Emergency Care Network. We have noted the inquiry's aims and its terms of reference. The College presented oral evidence to the Northern Ireland Assembly Health Committee on issues surrounding emergency care departments on the 26th of March 2014. Our evidence focused upon how the issues that manifest themselves in emergency departments are symptomatic of wider problems in our health and social care system and derive from a lack of progress in the implementation of the Transforming Your Care policy. We are seriously concerned that targets have become more important than people, that financial break-even takes precedence over the statutory duty of improving quality of care, that too often care is not being commissioned or organised around the patient, and in that context, it is neither effective nor efficient. At the outset, we want to acknowledge that Northern Ireland has some excellent health and social care professionals and arguably some of the best nurses in the world. That the majority of people who access and receive health and social care in Northern Ireland provide positive feedback, and indeed many would testify that they would not be alive today or enjoying the quality of life that they experience but for the excellent care that they received. The RCN, This Is Nursing initiative, spells out that nursing is a profession where joy and sadness come in equal measures, where inspiration is met by frustration, and where courage must outweigh fear. Professionalism relates to a set of values, behaviours, and relationships that are integral to the regulation of the profession and underpin the trust the public places in nurses. There is a fear amongst many nurses that the abnormal is becoming the normal, that on occasions compassion is constrained by pressure or displaced by stress, and there exists a desensitisation to poor standards of care. There is a perceived disconnect in some places between frontline staff and those in leadership and management roles, and nurses' concerns, when expressed, are not being heard or they're being ignored. Nurses are overwhelmed by the demands put upon them. Many feel demoralised, disempowered and stressed. Staffing levels in many areas are wholly inadequate, and normative staffing ranges agreed by the profession and endorsed by the Minister are yet to be implemented. HR policies, slowing recruitment and freezing and removing vacant posts as cost-saving measures have resulted in nursing teams becoming depleted and an over-reliance on bank staff. The College has been ineffective in our attempts to highlight that these cost-saving measures, which are neither cost-effective nor efficient, pose a significant risk to the quality of care, patient safety and the patient experience. This is evidenced in the HSE staff survey published in July 2013. Staff, when asked about the support to do a good job, 47% responded that there were not enough staff to do their job properly, 70% of staff were working more than their contracted hours, and 34% working up to 5 extra hours per week. And only 27% felt that communication between senior management and staff is effective. Only 59% felt that the care of patients is the organisation's top priority, and 56% said that they would recommend their organisation as a place of work. The Royal College of Nursing believes that this is a time for strong professional and clinical leadership, staff engagement and empowerment, because that is fundamental to the delivery of safe and effective care. We're happy to answer any questions that you might have for us. Thank you.
Janice, thank you, and your timing is excellent. You've set out there, I think, pretty clearly some of the key resource and the non-resource issues for us. I wondered if, as a first question, is how would you tackle those issues, the ones that you've set out there in terms of impairing the quality of care, that targets are more important than people at times, the staffing issues, etc. What do you think is the answer to those issues?
I think that experience tells us that we, the system, and we include ourselves in our organisation as being part of that system. We're there to promote the professionalism of nursing and to support nurses. But I think that we have been looking at the symptoms of a system that's not working for far too long, and I don't believe that we're very good at doing the diagnostics as to why that is happening. We move too quickly to solutions which deal with the symptoms and don't deal with the disease. We're not saying that the problems that's been played out in our emergency care department are easy to fix. If they were, we would have had them fixed. They're very, very complex. They can't be resolved by nurses alone. And we don't believe that people are asking the right questions around those. And we had a list of some 23 questions, which I have with me today, on our Evidence to the Health Committee, where we believe that people needed to ask, for example, who is coming to our emergency departments? Do they need to be there? Are there any alternatives in the community? Are there any means of accessing or alternative means of accessing acute services? And there's a whole list of things that one needs answers to questions, we believe, before we can move to solutions. What we do know is, we know about the demographics of our population. We know that more people are living longer, and that is a very positive thing. But more people have long-term conditions, and we cannot continue to deliver a health service that was designed many years ago for a different population to the population that we've got today. Everybody knew that, everybody knows that, and yet we don't have enough alternatives in the community to look after people with long-term conditions, and when they need diagnostic test done or an assessment, we don't have any other way of doing it in a lot of places, and it is starting to improve other than through the front door of our hospitals, which is the emergency care department. And persons, the system made that the front door, and I think our members would say it is not the fault of the people of Northern Ireland that they arrive in our emergency department. They wouldn't be there if there were alternatives, many of them.
Okay. Can I push you slightly in terms of, you'd said that there's a tendency to move too quickly to solutions, quick fixes, if you like. Can you give us an example of where you think departmental boards or trusts have gone for a quick fix or too quick a solution that actually is counterproductive or counterintuitive? Can you give me a sense of what that means in kind of reality?
Well, to describe what we are saying is that the problem that's been played out in our emergency departments, some of them, there is no doubt that there were staffing issues in those departments to care for that number of people. There's absolutely no doubt about that. Mm-hmm. The college is on record. We wrote letters about that very matter. But you can put in temporary staff to deal with the influx that you have got in that environment. Mm-hmm. But that is not what is required. It is required in the immediate short term because you have to care for the people, obviously. But the emergency department is not a department for providing nursing care or any kind of care to patients. They were never designed to do that. And therefore, whilst some may think that when you put 40 extra nurses into one of our emergency departments that's it sorted, but it isn't it sorted at all, because we need to understand who are all the people that are coming to there. Did they need to be there? When they're assessed, what are the assessments like? Are we admitting people appropriately? Are we discharging people too early? Those are all the questions that need to be asked about. And are we truly running a 24/7 service? And I think even today, if you walked around our hospitals in the middle of the night, there are not too many people about. You have the nurses, the doctors, the porters, a few staff who look after the environment, and maybe a night sister. And the car parks are empty. And it all builds up during the night, and then we go at it to try and clear it, and then it all happens again because the support Toronto 24/7 service isn't there.
Okay. My second question is about colleagues will pick up the participation and involvement in planning of services, both in providing services and planning, etc. But I'm interested in, we had evidence in the RQIA report of a bullying culture, I think it was described as in the Royal. We've had other evidence before us that is an issue. From your position of representing nurses, is the issue of the treatment of staff and bullying a problem? And if so, is that an issue that's across the piece, or is it one that's hospital A, B and C are much worse than hospital D, E and F? So if you can give us a sense of whether that's a big issue for you as a trade union representing your staff.
Garrett heads up our employment relations function, and I'm going to let him answer that because he's across that very well.
Thank you. It certainly is an issue, and certainly from an employment relations perspective, we do have a number of members and have had members who have contacted us over the past number of years, an increasing number, who would say that there is bullying attitudes and a bullying culture in relation to targets and in relation to achieving waiting time targets in relation to the emergency departments. Certainly there would be some areas, it's difficult to have a picture in terms of the exact areas, but certainly there would be some areas would be more than others, but it's fair to say that it would be something that would be experienced in most areas, in our experience.
Okay. And when you deal with the trusts about that, how do they respond to? Do you tend to deal with it about individual cases, or do you have a kind of broader?
Sure, I think what we have in relation to policies is an inadequate policy in relation to dealing with it. The policy which most of this comes under in employment relations terms is what's called the working well together, and that's a very formalised process, and rightly so. This is very, very serious behaviour, but I think a lot of this comes down to a lack of engagement. It comes down from the culture in terms of performance management and what has been created in terms of holding people to account, and that is something that we believe is a major factor in contributing to these sorts of behaviours.
Can I just add to that and say that in all of our dealings, and I have worked in the college now for 9 years, I've been its director for 5. I have never met, in inverted commas, in all of my dealings, a bad person. And I think that some of the people whose behaviours are being perceived as being totally unacceptable, and as reported they are totally unacceptable, I think that they are, to a degree, and this is not an excuse, but a victim of circumstance. I also believe that this is all about leadership, and the leadership from the top and from the bottom. And I think that organisations know that the behaviours are unacceptable. I believe that on occasions they turn a blind eye to them. And the most important thing is how many 4-hour and 12-hour breaches do we have got? And if you keep everybody from our door in relation to that, well, it doesn't really matter how you achieve it. The problem is it totally disempowers nurses. It certainly disempowers team leaders, ward managers, and those people who are saying we do not want to put 3 extra beds up in our wards. We have got no privacy screens for those people. We have got no nurse call bells for those people. We are compromising the infection control spaces between our beds, and on occasions we're blocking fire exits, and actually we don't have enough staff to look after them, and they are told to get on with it. And that causes untold stress to nurses who know that that is totally unacceptable.
Just one final question on this issue before I go to my final one. You said at times they turn a blind eye to it, or management turn a blind eye to it. Why do you think that is? What's the motivation for not dealing with it?
Personally, and from our experience, I believe it's to do with the target itself, and achieving the target is the most important thing. That is the culture that has set in, and even some of the language that's used, like breaches, the fact that patients are trolley weights, it's almost dehumanising, and that sort of language isn't acceptable. But it's the achievement of the target out trumps all the other important issues, and Janice has mentioned that in her initial submission. Okay, my final question, then I'll pass you to Barry, is I know in some of your evidence you've taken view, and some of the evidence that we've had from people who've talked to us is about the importance of a whole systems approach, and in fact it's not just the emergency department you should focus on, but it's all the other ancillary services, and making sure people go to the right place for the right treatment, etc., and have the right kind of social care response and aftercare, etc. And I wonder if, from your perspective, in terms of what that would look like in practice, have you seen any good examples from within the trusts where they've actually attempted a whole systems approach and it's worked, and if so, where and what made it work? Or are we really a long way from even getting to that kind of first base anywhere in Northern Ireland in the hospital department?
I think there are examples of conditions that professionals have sat down and worked out what is a proper care pathway for an individual with this condition, and how do we get them, how do we escalate up the input that they need? When do they come from the community into secondary care, and how do they go back out? When we run regional services, how we get them from peripheral services into the regional service to get the treatment, and how do we get them back out? There are some examples where that works very, very well. The problem is we talk about patient-centred and patient-led care, but actually, if we looked at some of our services from a patient's perspective, we wouldn't plan them and do them the way we do them. But there are some examples, yes, of where I think that it does work better than others.
Would you care to name names in a positive vein?
Would you like to have a go?
Example, even?
Yeah, well, for example, 2 of the trusts have very efficient and effective emergency nurse practitioner services, which means patients coming in with minor injuries will be seen, treated and discharged in extremely timely fashion. They actually are taken out of the main waiting department and are in a different stream altogether, so it means that the medical staff can focus on those patients that are sicker, and the emergency nurse practitioners can see the patients with minor injuries and minor illnesses.
Okay. I think when you talk about our services, if you look at some of our cancer services, some of our cardiac services, you will see those care pathways well developed. I know that there are occasions, certainly in cancer services, where it hasn't worked for clients, but that has been more about the patient not being managed properly than the fact that the care pathway is not there. For the patient, it doesn't matter what it was, it didn't work, and we totally accept that. But there are some examples of where it is working, and those are the models that we need to be looking to see how can we replicate that and make it work for all patients.
One final question, very briefly, is just to follow up on that. That's an example of good practice in 1 or 2 trusts. Are there any impediments? I mean, does that kind of good practice eventually roll out across the hospitals, or does it stay in 1 or 2 places? I mean, what's your experience of how good the health services and emergency departments of saying, this works, let's try it everywhere else? Is that level of kind of communication there between the trusts, or does it tend to be localised?
I think there is communication between the trusts. However, I'm not convinced that we learn that well from each other.
Okay, and what's the impediment there? Is it just time, resources, or something else?
I think there's probably quite a few things, time and resources in it, and then I suppose another thing is different departments work differently, would have different clients coming to the department, so their needs may be different. But for whatever reason, there seems to be a reluctance to benchmark and to mirror other departments in their good practice.
I think just on that point is around commissioning as well, the consistency around that, where we have tried and tested good services, why they're not replicated in other areas, and that's the commissioning responsibility.
Okay, thank you. I'm going to pass you to Marion.
Good afternoon. I have 3 questions. One on skills mix, one on the particular needs of the client group, and one on admissions from the nursing homes. In relation to skills mix, could you outline the RCN's view on nursing cover and skills mix in emergency departments? And could you include in your response your views on the impact of emergency nurse practitioners and the CNO's commitment to the development of advanced nursing practitioner roles?
I'll defer to my 2 colleagues because they're both emergency care nurses and they're the best people to respond to that.
Okay. I think if you spoke to any emergency nurse, they would tell you that if we were dealing with emergency patients alone coming through the doors, that probably our staffing levels would be adequate. However, when you then throw into the mix patients that are waiting on beds or waiting long time for transfer or waiting transfer back, that makes it a very different story. And I think if you walked into any emergency department and asked staff without using a staffing tool, did they have enough staff, they would say that they didn't. At the moment, there is NIPEC are looking at developing the BEST tool, going around each of the trusts to evaluate staffing levels, and I suppose the RCN can't emphasise enough the importance of adequate staffing levels, and not just that a nurse is a nurse is a nurse. It needs to be trained emergency nurses looking after patients, as opposed to a bank nurse that has maybe come from another area and never worked within the emergency department. That actually has a huge impact on the workload for staff, because if it isn't somebody who's experienced in an emergency department, then that really narrows the field that they can work in, or the particular area that they can work in, and that goes for our healthcare assistants as well, our healthcare practitioners, that if we're getting bank healthcare practitioners, again, they need to be able to work within the emergency department, otherwise it narrows their scope. The Emergency Care Network was very grateful to the CNO to look at the emergency care framework, and we have certainly started work on that. And what we would hope to achieve at the end of that is to have a career framework for emergency nurses right across Northern Ireland, so that you would know when you come into emergency care as a career that you will have a pathway that will lead you through experience and training, to ensure that you can then provide good, effective care to your patients. Our slight concern about that is that we will need the trusts and indeed the Health and Social Care Board to actually buy into that piece of work, because if we have come up with a framework, we need to ensure that that is then implemented in, otherwise we'll be back right where we started.
Yeah, just to add, and certainly what Roisin says has been positive things that have happened in the last probably 6 months, but it's quite sad that it took the crisis to develop really until some action was taken. We have been raising these concerns for some time. We have, I suppose, or the system has allowed departments to develop to a point where staff are working under so much pressure that there was increased sickness absence levels. Staff were leaving departments, members were distressed, working additional unpaid hours, and continually asked to work extra shifts at short notice. Because, as Roisin described, you have what effectively is a ward of patients in the middle of your emergency department, and that has led to a point where, yes, something has been done about it, but we have examples where we have departments, maybe over 50% of the nursing staff have less than 1 year's A&E experience, and A&E nursing is a specialist field. It is something that requires unique sets of skills and competencies. It requires support in terms of development and training and education, and that takes time. That's not something you can generate overnight. So we are at a point, yes, where we are, or the system is looking at it. It is a terrible pity that it has taken that long to do that, and it's going to take great effort and resource to bring those new staff who are now being, I suppose, inducted at haste almost to the environment, the ED, to bring them up to a level of competency and skill that is required. Some examples, for example, in assessing patients in triage, and the RQA did report on this in Belfast, staff being put in areas where they are not properly trained or to a level that they should have been trained and have the necessary experience. That's unacceptable.
Can I just check on something, Roisin, that you said earlier, which was that there were 2 trusts who had emergency nurse practitioners? Does that mean they're not?
No. Every trust, we were talking about examples, and every trust has emergency nurse practitioners.
Two particularly good examples. Just wanted to clarify that. Looking at the particular needs of some client groups, I'm just wondering about your views on the adequacy of emergency care for particularly vulnerable individuals such as children or those with mental health needs, and how effective you think the system is for the early identification and assessment of their needs.
Again, my colleagues can make some supporting remarks if they wish, your comments, but again there are examples of good practice. And I can't remember how many years ago now, the nurse who won the RCN Nurse of the Year was a male nurse who had a role as an alcohol liaison nurse, and he worked in the emergency departments, and his service was highly evaluated, and when he left that post it wasn't filled. And this goes back to something that was asked earlier about when we have good practice in place A, do we roll it out in place B? And the college would be very critical that year after year in our Nurse of the Year awards, step up nurses who have looked at the care they're providing to patients, recognised that it could be done better, worked to achieve that, and then won an award, and everybody goes, what a wonderful piece of work that was, and nobody goes, could we do that anywhere else? Should we be doing that everywhere? So I think that the people that nurses are most concerned about, and indeed it was a subject of debate at Congress this year, are people with addictions and mental health problems and older people. They feel that when they come to the emergency department that their care is not of a standard that it should be, that many of the people who come with addictions have underlying mental health problems that are not being appropriately addressed. We know that our country in particular has got a problem with mental ill health. We know that we're not doing enough about it. We have known that for some years as well. And I think that whilst it is starting to improve with addictions team, hospital diversions teams, crisis response teams, and I think some of our trusts have got excellent examples of that, by the way. But again, back to Garrett's point about what is the Health and Social Care Board's role in terms of commissioning, and how do we make that change happen if it's right for all of the people of Northern Ireland?
Just as an addition in relation to older people in particular, I think when you look at the figures in terms of those who wait the longest, it's our older people and most vulnerable. And I think it is a sad indictment on our society that we accept that. We don't allow it for children. We have separate streams for children attending our emergency departments in most of our, in fact we have separate children's unit within Belfast Trust, and we're moving in a number of different departments to have a separate paediatric department. I think the care of older people is something that needs to be prioritised, and pathways that are individually focused on that person needs to be a key priority, because a number of those patients to find themselves in an emergency department on a trolley and having to wait for so long to access the most appropriate care is totally and utterly unacceptable, and we're failing them. The system is failing them.
And my final question relates to, in March of this year you made a submission to the Health Committee in which you expressed that nurses were frustrated at the number of elderly people from nursing homes who are routinely admitted to emergency departments without having any clinical assessment regarding the necessity for such a move. I'm wondering, could you comment on any current developments to address that issue, and if there has been anything put in place, what is it achieving?
Nurses do raise their concerns about that very issue, which is why obviously we had it in our submission. I think that there's not a simple answer to this either, as you would expect, but what I will say is that where there is good individualised care planning for patients, and where those care plans explicitly address the longer term needs of the patient, where the registered manager and the home recognise that their skill mix within their team needs to address the needs of their clients, and they skill up that nursing team, it has a massive impact on the quality of life of people living in nursing homes, because if they need intravenous antibiotics, if they need IV fluids, if they need catheterisation, the nurses in the home, supported by GPs, will do it. But it is a multidisciplinary approach to care, and it requires a degree of different thinking. Last year, not this year, the nurse who won Nurse of the Year was a registered manager of a nursing home, and she was devastated, as were her staff, when a lady who lived in her home for 10 years was transferred to hospital and died in an ambulance. And as a result, she negotiated with the local GPs and skilled up her staff, supported by the homeowner, obviously, who paid for it, but skilled up the staff to make sure that they could give the best quality of care to their patients. But it does depend on, of course, very good relationships with carers and families, and an understanding of what their perspective is in terms of how they wish the person to be cared for and how they wish to be cared for themselves, if they have the capacity to have those discussions. So the frustration in it all is that people talk about all of these numbers. I go back to addressing the problem without knowing exactly what the problem is, and I think that work needs to be done, real work needs to be done, and people will say, oh, the GPs won't come out to see them and they're sent in hospital in an ambulance. Well, you know, I think we need to know which GPs won't come out to see them, and, you know, what are we doing about that? And finally, I would say that for many of the people who live in nursing homes and access services, it is very difficult if you need an X-ray of an older person's hip, and the only way you can get it is to send them through an ED department, and something needs to be done about that as well, because that's not acceptable. So Monday, Friday night, 9 to 5, you might be able to access an X-ray. A GP might be able to, but out of hours that's not the case, and that results in some older people lying in our ED departments for up to 8 hours to go through a system to have an X-ray that could have been done elsewhere. So I think that the importance of professional development, and the other thing that I should say before we leave this topic is the Health and Social Care Board did commission the college to provide leadership programmes for registered managers in independent sector homes and for their staff, looking at developing those skills. That programme has been very highly evaluated, and has actually, the RQIA have told the college that has made, they see that as having made a real difference. So there's also something about partnerships around how we develop staff who work there to provide appropriate care to patients.
Thank you very much. Thank you.
Okay, Paul.
Thank you very much for your time and for your help this afternoon. And we are over time, actually, so I'm going to try and keep my questions very crisp, and perhaps you can try and keep your answers crisp too. Firstly, you have talked about this, and I'm afraid I haven't quite caught it yet, so could you clarify that as a rule, are your members involved in the commissioning process in relation to the board? As a rule, are your members involved in the commissioning process to the board?
We have 14,000 members, and some of them are very senior nurses, and some of them are healthcare assistants. So in that respect, yes, some of our senior nurses who are members of the Royal College of Nursing are involved in the commissioning process.
Okay. And do you hear a wish for more involvement of your members in the commissioning process?
The Director of Commissioning did a fringe event at RCN Congress at the request of the college this year. He did a presentation at that event, and we are appreciative of him doing that. But afterwards, our members, some of them came to us and said we would like actually to have some kind of an event to discuss commissioning and how it should work and how it is working, because we want to be able to ask the right questions. So I would say at the moment that goes to the heart of engaging staff, and at the moment there's too many staff are not being engaged in any decisions about the delivery of care, let alone how we commission it. But there are some members who are, and where they are, they're doing a good job.
And the sense is that you get that your members would like more engagement
Yes.
with the commissioning
Yes.
process. Okay. And what about the RCN? Is the RCN itself involved in the commissioning process?
No, other than we see the commissioning directions when it's published, but we make it our business to be involved, and we have had meetings with the Director of Commissioning. In fact, I've just met with the new Chief Executive today. Our views about commissioning and how it is working are well known, and we have said it has to be about more than channeling out money. It has to be about what is appropriate for a population of 1.8 million, how much does the commissioning process cost, what do the people of Northern Ireland get for that, and what quality standards are in that process. And the other thing, just before I leave that, and I know we are out of time, but I want to say this, and it's about raising concerns, and I know that you were talking about that earlier to the previous witnesses, but when we have a system that has got the problems with access that we know it's got, the problems with waiting in our emergency departments, extra beds up, patients in the community that can't get care. I mean, my response to people asking why do nurses not raise concerns is, on one level, why would they? Everybody knows that what we're doing is not working. And the sooner people accept that and get round the table and start to fix it, the better.
Okay, but to go back to my question, which is about the commissioning
Yes.
process, so the RCN makes space for itself to be involved in the commissioning process?
Yes, I would say
Okay.
we lobby.
Okay, thank you. And the RCN Emergency Care Network,
Yes.
it might be a long story, but if you could be as brief as possible, could you briefly educate me? Could you comment briefly on the RCN Emergency Care Network and the Emergency Care Framework?
Okay, so the Emergency Care Network, quite a number of years ago, there used to be forums through the RCN that would be professional forums that members would link into, and there used to be a local forum. Then the forums were disbanded, and there are networks that link with the National Steering Group for Emergency Care. So this is a group of emergency nurses who would be there for RCN Northern Ireland to dip into for knowledge experience, also to provide study days for emergency nurses, to look at support for emergency nurses, and then to host days like we did with the Emergency Care Summit.
Okay, thank you. Would you characterise morale in your profession as being low?
Absolutely.
Yep.
Yeah. Not on, if you ask the 14,000 members, not all 14,000 members would say to you that they feel demoralised, disempowered, and, but it is a very common thing. Yes.
We've heard evidence that nursing care is sometimes brilliant, sometimes it's exemplary. That's what we've heard. We've also heard that nurses are sometimes rude and lacking in compassion. Would you care to comment on that?
Yes, I think that nurses themselves are concerned about that. I think I said in my opening statement, that they feel that the pressures are constraining compassion, and the stress is causing attitudes and behaviours to be expressed that are totally unacceptable. That is a matter of serious concern for us in the Royal College of Nursing. It is why every day we do what we do, because if the profession loses the faith of the public, it will be, a really sad day. So that's why we are as forthright as we are, and that's why we are so concerned that the way we're running the health service and the cost-saving measures that we're doing to try and meet the financial break-even is totally detrimental to a profession that is built on care. It takes time to care. and the human beings are not widgets to be pushed in and pushed out.
Yeah. And I'm
But it's
very-
not acceptable.
Yeah. And if or when it arises, what do you do about it?
We have got a professional development part in the college, a directorate in the college. We run programs. Those programs are very highly evaluated. We actually do coaching, so when there are problems in teams, some of our staff would often go out and try and do some coaching to help that. But when people come to the college, members or non-members, we make it very clear what their duties are in accordance with their code and what their obligations are, and that regardless of what is happening around them, their first duty of care is to the patient, and that is not acceptable. And I would say that there are issues about how people are supervised, and bearing in mind so few have appraisals and so few have clinical supervision, even though we have a policy and our profession is now moving to revalidation. I think that those are matters that should be picked up way before they ever get to that.
Yeah, just a point from my world in employment relations. What I say when we have members who find themselves in difficulty, we represent, we do not defend. We absolutely will not make excuses, and we don't defend the indefensible, and we always will condone where there has been poor practice, absolutely.
Thank you. And lastly, just briefly, in your advocacy and work, do you adopt an explicit human rights-based approach to health? Do you use the explicit language of human rights? And I'm not going to go through the discussion you probably heard earlier, but I'm interested to know just briefly whether or not you sort of routinely use the language of human rights and the human rights analysis when looking at the functions of the RCN.
I think that when we, in a policy context, when we are responding to policies and consultations, I think that if you were to look at those, you would see that there is a human rights value base in them. Whether you see the explicit language or not, probably not, I would say. But I would say that for a profession that is absolutely built on the core values of dignity and respect for human beings, that's non-judgmental, that everything that we do has to have a human rights foundation. Using the language, I'm not sure. Something to think about when we leave here. Will it make a difference? Let's hope so.
It's always a bit of a puzzle to me why the values are okay, but the language of human rights not. In any event, thank you so much, and I don't want there to be any misunderstanding. I'm full of admiration, as so many of us are, for the brilliant work that you and your colleagues do.
Thank you.
Janice, I'd just like to thank you and your colleagues. That's extremely helpful, and make the same offer that we've made to all witnesses. If you want to augment anything you've said today, or if you think we've missed any issues that you think should be drawn to our attention, we're happy to take a follow-up written submission. We have a number of the documents that you've submitted to various inquiries anyway, but there's an open invitation to do that if you so wish. And thank you very much for coming in this afternoon.
Thank you.
Thank you.